Let us continue with the third session of the therapeutics of glaucoma. We are here. After further discussion with the patient, it is determined that she has not been adherent to her dorzolamide therapy because of intolerable side effect, stinging and the foreign body sensation in the eye. The dorzolamide is discontinued and replaced with the triopost. Triopost is the prostaglandins analog, one drop, both eyes once a day at bedtime. Why might this drug selection be not appropriate for this patient? Because as we seen, it is a prostaglandins analog is the first line agent. It should be given the first, and we already started with the first line, and we came to the beta blocker and carbonic anhydrase inhibitor. So this therapy may not be useful. Second thing, this triopost is responsible for the change of the color eye. So why might this drug selection is not appropriate, and what patient education information should be provided to this patient about travoprost side effect? Travoprost is responsible for the change in the color of the eye, the brown color or maybe the blue color is due to the travoprost. So patient should be aware about the after use of this travoprost, they might be the change in the color of the eye, thickness of the eyelashes, and increase in the size of the eyelashes. And this drug is not appropriate because this is the first line agents we already used. Case 2, a 50-year-old woman with blue eyes presented for routine ophthalmic examination. Visual acuity without correction was 2080 and 2040. Tonometry measures IOP 40 millimeter Hg in both eyes. So IOP is increased 40 millimeter. Ophthalmoscopy reveal physiologic cupping of the disc, and cupping of the disc indicates the open angle glaucoma in both eyes, and visual field examination revealed nerve fiber bundle defect. Same finding with the previous case. Nerve fiber bundle defects consistent with the glaucoma. Pupils were normal in both eyes, so open angle glaucoma. Gonioscopy indicated that anterior chamber angles were open in both eyes, indicates the open angle glaucoma. There were no signs of cataract. Patients and presently is being treated for hypertension, chronic heart failure, chronic obstructive pulmonary disease, and asthma. It is very clear. If the patient having the same, near about same symptoms as per the previous case, but remarkable is cardiovascular and the pulmonary symptoms. So because of this cardiovascular and the pulmonary symptoms, we are not able to use beta blocker. What findings on examination indicates that the patient has primary open angle glaucoma? You can write IOP 40 millimeter of Hg. Then there is a cupping of the optic disc in the both eyes, nerve fiber bundle defects, and anterior chamber angles were open. These are the indicates the patients having the primary open angle glaucoma. What other factors may predispose the patients to increase IOP? Here, the blue eyes, old age, plus patient is being treated for this many conditions of the CVS and the pulmonary. So we can say the drug induced glaucoma, and due to these drugs may able to induce intraocular pressure increased. Can betaxolol be used as a therapeutic treatment in this case? If is justify, if no, what do you recommend justify? As the patient having the problem with the heart and the lungs, so we cannot give non-selective beta blocker as well as beta 1 selective. We cannot give betoxolol because it is beta 1 selective blocker, and it will trigger the chronic heart failure symptoms in the patients. So which drugs are suitable? You can use prostaglandin analog, and you can use carbonic anhydrase inhibitor topical as a primary therapy. 2 weeks after initiation of therapy, so we are using here prostaglandin analog, pros derivative, and topical carbonic anhydrase inhibitor derivatives. 2 weeks after initiation of the therapy, the patient returns to the clinic for follow-up evaluation. Now 31 and 32, before it is 40 in the both eyes. Yeah, there is significant reduction. She denies non-adherence and has no complaints of intolerance side effect. How should therapy be altered? Are there alternative dosage forms or drugs can be used? Now, if the benefits is not significant with the single drug, start with the single drug, suppose prostaglandin analog, and evaluate the patient for some weeks. If it did not get benefit, then you can add another second line agent, that is topical carbonic anhydrase inhibitor, to the first line agent, that is prostaglandin analog. Review the patient initially for some weeks, and if the patient is not getting benefits, again for the addition of carbonic anhydrase inhibitor to the prostaglandin analog, you can replace the drug with third line agents, which are adrenergic agonist, and other agents which are the myotics. So I will go to the again this. Yes, these are the drugs. You should start with the first line agents, prostaglandin analog. Beta blocker should be contraindicated because the patient has the heart problem and the lungs problem. You can add prostaglandin analog. You can add carbonic anhydrase inhibitor to the prostaglandin analog. You can also add topical adrenergic agonist to the prostaglandin analog. Initially evaluate the patient for some weeks and then take the decision for third line agents, that is the pilocarpine or dipivefrin. And you have the last option with the carbachol, topical cholinesterase inhibitor cecothiopate, and oral carbonic anhydrase inhibitor. And the last case, case number 3, this case is for the closed angle glaucoma. A 72-year-old man present to the emergency department with an intensely red right eye, a streamy appearing cornea, complaints of halos around the light, and extreme pain. The extreme pain indicates the closed ankle glaucoma, and intraocular pressure was 70 millimeter of Hg. A diagnosis of acute angle closure glaucoma is made. and timolol eye drop therapy was started to prepare the eye for surgical treatment. Now, this is the case of closed angle glaucoma, and here timolol, which is a beta blocker, is started to prepare the eye for surgical treatment. Do you agree for the prescription of timolol therapy for this patient and justify? We are not using timolol to prepare the eye for surgical treatment, so timolol is not the best drug. In other hand, timolol is also causes tachyphylaxis reaction and decrease the response to the drug. So timolol is not a good choice. Instead of the timolol, if the intraocular pressure is more than 60 and 70, the miotics drugs are not useful, because if the intraocular pressure is 70, there is a ischemia of iris and there is ineffectiveness of these eye drops, including timolol. What is the drug of choice for the treatment of this case of glaucoma? Mention its route of administration. The drug of choice, as we discussed, the mannitol. Osmotic diuretic mannitol should be given by intravenous route, and once the intraocular pressure is get significant decreased, then we can use miotic eye drops, including pilocarpine. If IOP is still elevated, what are the alternative dosage form or drug that can be used for the treatment of this patient? If with the mannitol IOP is still elevated, with the use of mannitol intravenously, you can use another dosage form, glycerol by the oral route, glycerin by the oral route, and you can use acetazolamide, which is the carbonic anhydrase inhibitor, by the intravenous route. Which analgesic do you recommend for the treatment of this patient? This is a severe pain, extreme pain, which is not managed by non-steroidal anti-inflammatory drugs. So use pethidine or morphine. After control of intraocular pressure by the above selected drug, what do you recommend for this patient until the surgical treatment is performed? Once the intraocular pressure is get controlled, then patient can use pilocarpine eye drop every 6 hourly till the surgical procedure get performed. I hope you get the therapeutics of the glaucoma. Thank you very much.